What a great way to set the stage for the rest of IEX. I'm eager to celebrate innovation and VHA and partake in the thought-provoking discussions and inspire one another to solve the challenges facing both VHA and our veterans. For the next several minutes, we're going to spotlight immersive technology across VA. If you need to use the restroom, feel free to do so now. Otherwise, stick around to hear about the future and veteran impact of immersive technology. As the executive director of SimLearn, I have the privilege of working with a variety of collaborators to reimagine veteran care and design the future of healthcare-related simulation and training using a vast array of technology and innovations. In other words, I get to go to work and play with toys. It's great. One of the ways we envision designing the future is through simulation and training with immersive technology. Healthcare is complex, and we know to have maximum impact, we need to address critical elements like engagement, knowledge retention, access, and applicability. Immersive technology meets each of these and allows us to drive innovation forward. Today and tomorrow, you will hear a few examples that will highlight VA's current use of immersive technology, including augmented reality, virtual reality, and digital twinning. We'll even offer opportunities for you to see some of this technology demonstrated in real time. Seeing is believing, and experiencing is transformative.
Why am I getting angry? Because it doesn't seem like they have the act together. Hi, good morning. How are you doing today? Well, I've been better, you know? I'm getting happy that I'm leaving, but it's not till 2 o'clock. It's almost 9 o'clock in the morning, and the nurse now tells me I have a fever. I had a pretty painful accident, correct? Please let the nurse know if you're experiencing a lot of pain. Okay, I will.
do I follow these motions? Because it's like, give me, I like the up motion, I feel like my hands are.
Yeah, you don't have to follow the up motion fully, but you're totally fine.
If we innovate without adopting, it goes nowhere. There's a lot of innovation out there. People like you and me come up with these ideas all the time. But if we don't adopt it, or if we limit it, it reduces our potential to improve lives. We're fortunate to have leadership from VHA and various industries to talk about how we can build a foundation to do exactly that, to improve the lives of veterans. They're going to highlight what that foundation requires. Things like incentives, infrastructure, anything that's required to adopt innovation and scale it across the entire nation and VHA. The collective skill sets of these leaders will ensure that the transformation of healthcare for veterans includes an equitable, effective adoption. To introduce these leaders and moderate this discussion, please join me in welcoming Ryan Lilly, Director of the Veterans Integrated Service Network, VA New England Healthcare System, also known as Vision One.
All right, well, good morning, everybody, and it's great to be here. I am Ryan Lilly. I'm the Network Director in Vision One, and Vision One, we also host the New England Center for Innovation Excellence, which is part of VHA's innovation ecosystem. So it's great to be here to talk about adoption. And I'm joined by three fabulous panel members, and we've got a great chat planned for you this morning. I'm really pleased that we were able to do this early in the program. And as you think about these innovations that you'll hear for the next few days, it's really important to think, how do we get from innovation to adoption? Innovation alone without adoption really is a missed opportunity in my mind. And so we're going to hear from three industry leaders this morning about how they've done this in the past, and more importantly for us, what lessons they think VHA should take from their experience as we look to adopt in VHA. So let me introduce our panel members. First is Will Robinson. He's the Director of Policy and Strategy at Big Health. Latoya Thomas is the Senior Director of Policy and Government Affairs at Included Health. And Andrei Ostrovsky, the Managing Partner, Social Innovation Ventures. And well, why don't we start with you, just a brief minute or so on your bona fides here, what you bring to this space.
Yeah, sure. Thanks, Ryan. And thanks for everybody coming. Thanks for everybody that's watching virtually. It's really great to be here. Also thank the staff that put this together. I know these things take a lot of work, and it seems like a really phenomenal event, so thank you. So as Ryan said, I work for a company called Big Health. We're a digital therapeutics company, which means we make software, and in our case, we make software that treats mental health conditions. We have two products, one for insomnia and one for generalized anxiety disorder. Both products take a intervention called cognitive behavioral therapy, which is first line for a variety of common mental health conditions, and we package that in a smart, personalized, thoughtful, and automated software intervention that delivers that therapy in an empathetic and compassionate way. The human voice and animation play a big role, so even though it's automated, it feels highly personalized. We have a significant and growing body of evidence that supports our products. I think one of the big things in the digital space is, can you prove it works? And we have a variety of randomized controlled trials, over a dozen on our products, and also distribute in the UK and the United States.
Great. Welcome. Latoya.
Hi, everyone. Thanks so much for having me. Latoya Thomas. I'm the head of policy and government affairs at Included Health, formerly known as Grand Rounds Health, formerly known as Doctor on Demand. We went through a merger last summer and then acquired a company called Included Health and did the smart thing of retaining that name instead of having to come up with another one. At Included Health, we do some really, really interested work, really motivated by the fact that we understand that most patients throughout the country have a really hard time navigating a really complex healthcare system. And this is across the life cycle and across payment models, whether you have your insurance through your employer or getting it from one of the many government programs. Not every patient has an equitable experience in accessing not only just healthcare, generally speaking, but also navigating the complexities of their healthcare benefits. At Included Health, we really do strive to improve that experience for members across the entire life cycle. We do so through leveraging a variety of solutions. The first solution that we leverage is the amazing human workforce that we have with our employed clinicians throughout the country, and we make those clinicians available to our patients nationwide through the mechanism of virtual care and telehealth. In addition to that, the services that we provide there are urgent care, primary care, and integrated behavioral health. In addition to that, we do help patients navigate just the complexities of health insurance, acknowledging that oftentimes in conversations today, there's a lot of focus on digital literacy. Well, we focus a lot on healthcare competencies, understanding that most folks, even though I think generally speaking, roughly 6% of folks are uninsured or underinsured today, those holding health insurance today don't oftentimes know how to navigate the wonderful benefits that are made available to them, whether they're government sponsored or in the private markets. And we believe that improving the quality of care is one of the first steps to doing that, is really understanding how to get to a culturally and oftentimes gender-affirming healthcare provider that can get you the quality that you need. So we do so with a tech-based platform.
Great, welcome. Andre.
That's awesome. I love hearing you speak. Hi, everyone. I'm Andre Ostrovsky. Clinically, I'm a pediatrician. I doctor a couple times a month here in DC in the primary care setting. I spend most of my time investing in diverse founders that are trying to close health equity gaps. Most of my portfolio companies are tech or health tech-enabled service businesses. And my hope is that investing in helping issues around Medicaid, Medicare, and the VA, that will inspire more investors, frankly, to do what they do best, which is profit optimize. And I believe that I don't think we're going to change a lot of investors' perspectives on profit optimization, but I do think we can align their financial motives with doing the correct thing for populations that are most subject to health disparities. I've had a couple of operating roles and government roles in the past. I've founded a business over a decade ago in the readmission reduction space. I helped to turn around an organization, a series of methadone clinics, so nothing tech-related whatsoever, just bread and butter, evidence-based implementation. And that was a really great learning experience. And my most recent government role was as the Chief Medical Officer of the National Medicaid Program. That was a really steep learning curve. And so I tried to bring together all of those experiences and support founders in making sure that they're able to figure out how to navigate these complex ecosystems. And I'm simultaneously excited and frustrated, but we're going to address that frustration and improve the plumbing, and we're going to get it done.
All right, great. Well, welcome all of you. I'm really glad you're here. So when we look back at the last 5 years or so of healthcare innovation, a time of tremendous change, whether that's policy, regulation, the way patients interact with the system, et cetera. So I want to start our discussion with all of you looking into your crystal ball for the next 5 years and tell me, what does healthcare innovation look like in your mind in the next 5 years? We'll start with you, Andre, and we'll work our way across.
Sure. I could tell you what I hope it will be. And what I hope it will be is that this focus right now on health equity is not going to be a passing fad. We've seen SDOH become buzzy. I think the buzz is starting to die down and health equity is starting to pick up. And now, we heard about carbon neutrality and climate. That's going to be the next buzzy thing. And I fear that there's buzz and then it dies down and there's like the next thing to go after. And my hope, and I believe there's a real chance that this will happen, and that is that organizations, companies, the private sector will realize that investing through a lens of equity is a competitive advantage. Oftentimes it is a longer term return on that investment, not a shorter term. And as long as investors, entrepreneurs are willing to take the long-term time horizon that they are going to win out. I also think that the performative things around health equity are, organizations are going to get called out for it pretty quickly. I think we're starting to see it now. And I'm hopeful, again, that the powers that be, whether it's the regulation setters, the legislators, and the funders, that they hold the innovators accountable. And if we have time afterwards, I'm happy to elaborate on tactically what mechanisms could be put in place. And I can elaborate on the American Medical Association. For all the problems that they've had, they actually have a pretty good health equity strategy in place. And there's a body of work called infullhealth.org, I believe, that actually has 5 specific guidelines and strategies around how to walk the talk around health equity.
Okay.
So in 5 years, I'm hoping those types of mechanisms, and then a few of those investors that have actually made money investing in this way, they become the norm, and everyone tries to copy them. And for what it's worth, and not to get into the numbers, but my personal internal rate of return is 56% investing in this way. Wow. That's nearly double what it is for a traditional venture investor, including this downturn. I made more money in this year than I have in the preceding 4 years I've been investing. Wow. And that's making money by empowering diverse founders. It's making money by empowering companies investing in the Medicaid space or the MA space. Increasingly in the VA, but I'm still learning about the VA. So, that's what I predict and hope for the future. We'll see.
We'll see. Great. Latoya?
Yeah. I'd answer that question in 2 ways, I think. The first thing that comes to mind, because it's so personal, is my hope, as optimistic as Andre is hopeful that healthcare becomes more personalized. And then my second answer would be hopeful, and I don't think these are mutually exclusive, but hopeful that healthcare becomes more easily navigable. We understand kind of the current state of today, we're still living in a bit of at the very least, a COVID pandemic fog, but also operating under 2 other public health emergencies. We have monkeypox, we have the unfortunate substance abuse and opioid pandemic that just will not go away, but many are just trying to address, and many other things that are happening throughout the country from a social perspective. But if you think of the innovations, both from a human infrastructure perspective, but also from a tech perspective, the ways in which we need to figure out a way to address the pending healthcare provider shortage from an interdisciplinary perspective, better ways that we can leverage community health workers, or an iteration of that they might become in the next 5 years, credentialed or not. The ways in which consumers, if they choose to become patients, right? Because there's a difference between someone consuming healthcare and someone who's engaged in a provider-patient relationship, the ways in which they are wanting to become much more informed about healthcare, about their own health and wellness, and about the healthcare teams and healthcare systems that they have to engage with, both in network and out of network. And there are a number of regulatory frameworks that are hoping to unleash a lot of data to make a lot of that information much more transparent for them. But there are some gaps there. Knowing the cost of how much, or the anticipated cost of my healthcare, will help me navigate that, will help me make it a little bit more personable, especially if I have that information in mind with some of my daily cost of living. But not knowing whether or not the healthcare provider or system that I'm engaging with is one that will accept me, see me, hear me, or is one that's got truly documented quality outcomes is something for which I think that there's a gap, but I'm quite hopeful for. So I do think that in the next 5 years, I'm going to say 10, and in the next 5, 10 years, much more personable and hopefully more easily navigable.
Great. Well.
For what it's worth, Andre and Latoya, I think, are absolutely right. And I'll add, I guess, a slightly more clinical point, which is, I think, what we've seen, this is one of these innovations that I think has been happening for a little while. It's probably going to continue, which is this general shift from care that's provided in traditional brick and mortar settings to care that is provided in settings that are closer to where the patient wants to be, where they want to be, basically. And that a lot of the times that will be at the patient's home. It could be in other locations, but I think a lot of times it's going to be at the patient's home. An example on the mental health side is obviously our products, where our products are furnished. We are solving a gap in access to evidence-based therapy, and so patients can access that therapy through their phone wherever they want, where it works for them. I think it also is happening in digital first primary care relationships. It's going to increase on the specialty side, and I think you're also going to see, this is one of those examples where the VA has been leading, is a shift in inpatient services from inpatient facilities to the home. You saw CMS, the Centers for Medicare and Medicaid Services, build on work that the VA had done in a waiver that they allowed hospitals to furnish inpatient services at home during the pandemic. I think you're seeing plans get more interested in that concept, so that's another area. And I would say if you take a step back, I think the digital technology that we are all talking about, I think underwrites that transformation across the board. That does not happen without, they have to happen together. You have to have the leadership, the motivation, the clinical models, the adoption. That has to flow alongside the technology that supports the home monitoring, the evidence-based mental health services at home, or a telehealth platform that allows for that digital first primary care relationship. So yeah, I guess that's my crystal ball moment.
Great, thanks. So let's talk about VHA a bit. All three of you are obviously external to VHA, and I wonder if when you look at our system, what you see in terms of our size and our scale, and in particular, does VHA have a real opportunity here because of our size, our incentives to say we really could actually lead in some ways in this space? I wonder if you see it the same way, or am I overly optimistic about my own system? So Latoya, let's start with you.
I've always been impressed by the work that the VA has done. Prior to working at Included Health, I was head of policy at the American Telemedicine Association. So if you can imagine pre-pandemic, the VA being the largest and leading entity within the country to really put real table stakes down and even pilot innovative care delivery models like telehealth in the home outside of a home health benefit, right? Dispelling a lot of the myths about, how one can use government funding with integrity and being mindful of some of the buzz things like fraud, waste, and abuse. I do think that the VA, for it being the largest healthcare system in the country, and I have to go back to being pre-pandemic because other government programs followed the lead of other leaders from the VA. The Mission Act, the 2018 Mission Act that was passed prior to the pandemic, was quite innovative. I mean, we're in conversations right now where many states, from a cross-state practice perspective, are trying to figure out how they can embolden, how they can enable their boots on the ground, and even virtual boots in the cloud, healthcare providers to enhance access to care in their states, but also embolden their own patients to seek the types of quality care that they need. Those conversations are being happened now. There are a number of policies that are being rescinded or changed, and policy frameworks that are being debated about. The VA figured that out back in 2018. Granted, the Department of Defense did it first, but the Mission Act essentially allowed for all employed healthcare providers, not just physicians, but all employed healthcare providers, to be able to provide those services outside of a VA facility to a veteran or their family member, someone receiving benefits, without needing an additional license in another state. So figuring out a way to navigate healthcare using that kind of a framework is certainly something that VA has done. I think one thing that the VA can do in the future, this is kind of future forward, understanding the fact that we are currently living in and moving into broader provider shortages, is allowing that capability for contracted healthcare providers. As government systems become more privatized, just look at the community care program in which you have community partnerships with private entities, enabling them to follow VA beneficiaries and their family members, leveraging some of those really unique licensure frameworks, I think is something would be to the benefit, not just of the program, but to the beneficiaries at all, and be really forward thinking for some of the healthcare providers in the private sector that are still trying to figure it out and using some of the regulatory models that are available to them.
Great. Andre, anything to add to that, or Will?
Oh man, VA. I mean,
VA.
what a great sandbox, and then the sandbox that turns into a giant beach, and then it's like all of the sand in the world. I think the VA's done some amazing things really well, and it's kind of, in theory boring, but actually instrumental. But just looking at the approach to change management and a willingness to do innovation, I love CMS, but oh boy, I mean, that machinery moves slowly. VHA, like a lot of the work is done by the employed staff, but a lot of the work is also done by contractors. And if you just look at the contractors that are being used, how the contractors are being engaged with, these are contractors that have similar talent pools to the Googles of the world, or some of the talent pools around New York or Palo Alto or Austin. Like, this is the talent pool that is partnering with the VA to do cool things like Diffusion Marketplace, or to do analytics that really rival some of the biggest machine learning shops in the private sector. So that part the VA has down. They know how to contract well. And so change management capabilities, data-driven policy decisions are there. I think that the market, the total addressable market, very appealing to innovators, very appealing to investors. And so once you're in, it's amazing. The challenge is, how do you get in?
How do you get in? Yeah.
And I mean, I'm still figuring that out, and I'm not expert in that, but I think that it shouldn't require deep expertise to understand how to get in. And again, I know like Diffusion Marketplace is helping with that. I think more needs to be done so that you don't have to be like a 2 or 3 times successful founder that is well known to top tier venture firms to be able to have the opportunity to get access to the consultants who know how to access the VHA. Right. And if we're really talking about equity and like getting folks with really unique expertise that could create a ton of value building really interesting tech or services, but maybe aren't plugged into the good old white boys club, but helping them understand, all right, here's how to create value and just show what you can do, I think that's actually like a really interesting opportunity. And maybe that kind of stuff already exists. I'm just not familiar with it, and I suspect others may not be familiar as well. Yeah. And if that could be prioritized, I think we could see faster innovation and then more concordance, not just between patient-provider, but concordance between innovator, patient, innovator, provider. And that I think could be very interesting.
Real opportunity. Great. Will, anything you want to add on that?
I guess as usual, and we all know each other, and they're awesome, and so I'm not surprised that I agree with everything that they're saying. But I think, Andre, I'll build on something that you said earlier, which is that I think like government specifically has a very unique role, which is, unlike the private sector, government can think somewhat longer term. Like, there's no quarterly earnings cycle. It's just different. And so Andre made the point earlier about like having a longer term investment horizon to be able to focus on things like social determinants of health and others. And I think that is one area where it's very unique in terms of the VA, but I mean CMS too, but the VA as well as an integrated delivery system can take a longer view and invest in some things that is harder to, and actually can make markets around some things for organizations where they want to engage and partner with the private sector. They can do that as well. So
great. Let's talk a bit about hardwiring in this infrastructure. So wherever I go, I meet no shortage of enthusiasm to innovate, but what I see a lot is difficulty actually executing an innovation vision. And I'm wondering what you all could share from your experience in terms of hardwiring in this sort of organizational piping around infrastructure so that you actually can execute these great ideas.
Yeah, I guess I'll start.
Start with you.
So I think, like, when I think of infrastructure, I think about like innovation needing a home. So it's pretty easy in every organization. This isn't just a government problem, it's in the private sector too, to be like, this is how we do things, right? It's like, we have done this way.
Yeah.
We've done this way, it's the way it works, we're good. And I think when innovation has a place to live, has resources, it has leadership, it has commitment. It's part of the mission and the vision, the values of the organization. That can help a lot change that answer from this is how we do things to like, let's try to do it a little bit differently. The second point that I'll make is about a culture of innovation. Like, and what I mean by that is like, it's gotta be okay to fail. Like innovation is about testing new things, having them not work out, and then testing again, because it's really not about failure, it's about learning. It's about figuring out like, okay, why didn't that work? How do we do it a little bit differently? And then how do we try it again? I will use another CMS example here, which is that the CMS Innovation Center, which is designed to test new payment service delivery models, they've tested, and I'll back up for 2 seconds, which is the goal of the Innovation Center is to test those models so that then they get expanded across the entire program, right? The Innovation Center has tested, I think, 50-something plus models. It tests a lot of models. 3 of them have actually made it to the final stage. And that's okay. The country and the Innovation Center and CMS and all the information is public, we've learned a lot about how to do these things. And so that learning is what is actually incredibly valuable. And so I think that's my point is that's the point. Innovation, you shouldn't expect to succeed immediately, and that's okay. So.
Okay, Latoya?
The word that comes to mind for me, especially as Will was talking, was accountability. I think that we're hearing a lot outside of the VA for obvious reasons. One, because the regulatory framework is not quite perfect. I'll say that. I'll be nice today. And has some room for growth, some room for improvement there. But one thing that's hindering it is the request constantly that somehow we haven't proved ourselves, or there's a lack of efficacy, or that the innovators are not driven by quality outcomes, quality processes. I think slowly but surely, whether you are an incubator of innovation, whether you are a partner outside of that incubator for innovation, slowly but surely, I think that you're going to start to see entities holding themselves accountable, self-regulating, as opposed to needing a system like the VA or another government system regulating them for their innovations. And being a part of this learning process, I think, will allow them to hold themselves accountable and really be driven much more by some of those quality outcomes and processes than I think what we've seen in the past.
Great. Andre?
I think the VA has a really interesting opportunity in using its size and its credibility to push other organizations to help make the plumbing for innovation be more efficient and have more throughput in a high-value way. I'll give you an example. So I was in clinic recently, and I'm a pediatrician, so I had a kiddo with ADHD. And there's a new FDA, and to be full disclosure, I'm an investor in this company, and I disclose this to the family. There's a non-pharmacologic intervention available to treat kids' ADHD where you don't have the side effect profile of a stimulant medication. You don't have the unwanted weight loss or the sleep disturbances. And so there's an intervention where I could prescribe, and it's software. Like, it's a game that kids can play, and several studies have shown it works really well. In order for me to prescribe that as a physician, in the EHR, when I e-prescribe, that solution needs to come up just like Ritalin would come up, or a stimulant would come up. And that requires that compendia have that digital solution available. That also requires that the PBMs cover that on their fee schedule, which means it also requires that health plans push PBMs to be up to date with the most recent literature. And so I think that that concept applies in a really big way, where the VA identifies a clinical need for its patients. I think it can exert really interesting influence on compendia. I think the VA, in another example, psychedelic-based treatment. There is an enormous body of literature showing really impressive effect sizes on addressing refractory mental illness. A lot of that research pioneered in the VA. in order to effectively code for something, you need the American Medical Association to have CPT codes that reflect clinician time. There are no adequate CPT codes right now, and to AMA's credit, like they're currently processing kind of innovations around coding. What if the VA stepped in and said, hey, we have a huge need clinically. Here are our clinicians, here are our researchers. We're going to comment on this CPT coding process. That's a huge opportunity to influence. And then another scenario, LaToya mentioned the opioid overdose crisis. And again, I'm an investor in the solution, but there is a over-the-counter naloxone formulation that is currently sitting around waiting for the FDA to approve it, even though Dr. Califf has insisted on innovations to come out and offer over-the-counter naloxone. For $13, you can get a naloxone formulation that is more efficacious against fentanyl than Narcan. And FDA is sitting around going through its processes. Now, I give FDA a lot of credit. They have a real scientific rigor, but they are not quick.
Slow, yeah.
Could the VA come in and be like, hey, we have a bit of an overdose problem with our veterans.
Right.
Can you help offer this modality of treatment to our veterans and help accelerate that approval process? I'm not saying shortcut it. The scientific rigor has to be there, but apply the pressure so that the mid-level careers they have a lot to do, but if they get a priority to go do something, they're going to reprioritize their energy and apply the process. And I think whether it's AMA or it's the compendia or it's FDA or any other plumbing-involved entity in healthcare, the VA has a lot of muscle. And I think that muscle should be thrown around a little bit more assertively.
Great. I know we're almost out of time. I want to make sure we get the digital divide question in, at least briefly. So many of the solutions that we've envisioned really involved some level of technology into the future. And we know that technology is not readily available in the same way to all demographics. How do we solve that problem going forward, or how do we bridge that divide? Maybe I'll start with you, LaToya, on that one. It's a loaded question in 3 minutes, I know.
It's a loaded question, and I'm going to choose to answer it differently. I think that we default to technology being the problem too often. I think that we have broader problems broadly within healthcare. Internally at Included Health, we serve 9 million active duty service members, their families, and retirees, so we've got some experience there. But we also serve members and patients throughout the entire life cycle with different payers. For us, it is about the healthcare first. Yes, we have a proprietary technology, but it is about making sure that folks understand the healthcare, including our own enrolled healthcare providers, making sure that our members and our patients are seen and heard, making sure that our healthcare providers are trained, duly trained in the cultural competencies to serve folks and their intersectional cultural differences. So with respect to our active duty service members, their families and retirees, for us it's about learning their profession, learning their culture of being a serviceman or a servicewoman, in addition to their race, their ethnicity, perhaps their age, the stage in their life that they have, the fact that they may be transitioning out of the military in 6 months to a year, the fact that their family is following them from one country to another. And outside of that, similarly, being very in tune, very intuitive to what the needs of various communities are, but being open to the fact that how I identify today may not be how I choose to call it tomorrow, and making sure that the data can follow that too. I know I didn't answer your question, but I think that we default too often to technology being the crux of the problem. I think we have to start really zooming out a little bit, getting uncomfortable with the fact that we're all sitting in a really messy healthcare system, and embracing the fact that technology, in concert with all of us just kind of being at the table, can really try to improve it.
Great answer. We're just about out of time. Let me ask each of you a closing message, if you will, a call to action to the field, the thousands that are joining us remotely, as well as the folks in the room. One message to leave the VHA workforce with. We'll start with you, Andre.
Sure. I think the singular most innovative thing that can be done around tech innovation has nothing to do with tech. It's around payment model design. If you can go as far towards full financial risk as possible, that will solve all of our problems. Everything else becomes irrelevant. As long as we're married to a fee-for-service payment model, we're still dealing with short-term ROI, equity issues, if everyone's at full risk, everything falls into place.
Great. Latoya?
I'm going to double down on personalization, unleashing data, making sure that data is available, and collaboration.
Great.
I guess I'll, more of a personal message. My grandfather was a psychiatrist at the VA for about 10 years in Buffalo. Go Bills, by the way. And he treated a lot of patients and saw, and we have some letters from his patients that are very moving. And I often go back to them because it reminds you about why you're doing this. Like at the end of the day, that's really what it's about. And so when I think about innovation and the whole conference and the message to everybody, it's about how do we make it better? How do we make the care better? How do we make their clinicians' jobs easier? And yeah, how do we do better for everybody? So
Great. And I'll close with my own message. It's great to see some of our operational leaders here. In Vision One, historically, we really invested heavily in improvement work, and we used to say improving our work is our work. And I would expand that and say innovating our work is our work. We don't separate this from our normal operational duties. This is really part of the job of all the leaders, especially all of those of you listening in the field today. So this is your job, just like it's my job, and it's our responsibility really to do that. So thank you all for joining our session. It's great. Our panelists will be around for a few minutes if you want to catch them after, and that's a wrap. So thank you all.